Hello. We want to memorialize the day of the first transhiatal esophagectomy by Dr. Mark Orringer. And so we're very honored to have Dr. Orringer here to maybe give a little bit of background of the operation, some of the things that we can't pull out from the literature. So, Dr. Orringer, maybe just tell us a little bit about how you decided on this approach and the planning, and did it go as well as that you expected it to?
Well, this discussion about how we got there could really fill a long story hour. It actually begins back in the days of residency at a place called Johns Hopkins. And at that time, as a Halstead resident, when I had a patient with a malignant tracheoesophageal fistula who was a young woman and dying, the tumor was clearly unresectable because it was involving her mediastinum and her trachea and her esophagus. But she was dying not of the tumor, but of aspiration through the fistula. And in that patient, as a Halstead resident with all the autonomy that we had at that time, I did a substernal gastric bypass of the excluded esophagus, tying off both ends of the esophagus, stapling them closed, and bringing up the stomach retrosternally and connecting it in the neck so that she could swallow without aspirating. This patient did remarkably well, except she had an anastomotic leak. But that experience taught me two things. One, that the stomach could be mobilized to reach to the neck. And two, that a leak in the neck was far different than a leak in the chest where median stenitis killed the patient. You open the neck wound and drain it, and they do fine. And this set the stage for a difference in my thinking. I learned to do thoracic surgery with Dick Kiefer out at the VA hospital at Loch Raven. And it was an incredible experience, but for many decades, American thoracic surgeons had been trained that the stomach would reach to the apex of the right chest, but really no further comfortably. There are some reported cases from Asia that the stomach could reach further, but that was really it. But this patient that I had with a substernal bypass did have a stomach that reached to the neck, and it started an aha moment. And then I was Halstead resident then, but then I moved to Michigan as my first job, and it was there that I began to build a general thoracic surgery service that had languished under cardiac surgery and the growth of that specialty. And I quickly adopted a policy that there would be no more intrathoracic esophageal anastomoses to avoid the greatest fear we had, which was an intrathoracic leak and median stenitis. So in '73, all esophageal resections that we did involved an abdominal incision to free up the stomach, and a chest incision to free up the esophagus, and then a neck incision to pass the stomach from inside the chest up into the neck for the anastomosis. So now we fast forward to, it was 1977. It was February 22nd, 1977. And the reason I know this is that your request to have this little discussion threw the fear of God into me, and I had to run to my office. Ever since I've been a member of the faculty here, I have kept these patient cards on every single patient. So I've got like 5,000 patient cards alphabetically in my office of every esophageal operation we've ever done here. We stopped relying on an electronic, on a medical record, paper records long ago, but I found this patient's card here, and it described this 62-year-old man who was 5'7", 230 pounds, had a history of smoking, but had not smoked for several years, and had long-standing gastroesophageal reflux associated with a very, very large sliding hiatal hernia, 6 to 7 centimeters of stomach in the chest, not paraesophageal, but just a big sliding hiatal hernia. And his gastroenterologist had very astutely picked up on his a little more heartburn and epigastric distress than the patient had complained of before, not dysphagia, oddly enough. And he scoped him and he found a polypoid carcinoma at the distal esophageal, at the esophagogastric junction. On biopsy, it was an adenocarcinoma. Now, we weren't quite as skilled at staging patients at that time, but he had no obvious evidence of metastatic disease. I scheduled this patient for an esophagectomy, just as I told you we had begun to do routinely. An abdominal incision, a chest incision to remove the esophagus, and a neck incision. We reserved the requisite time in the intensive care unit, assuming we'd have a 10-day stay if we were lucky, and expecting a real postoperative struggle. And Dr. Yang asked about all the planning that went into this procedure. This is going to be a very short response. There wasn't any. In the operating room, this patient was positioned supine, and we had him draped so that I could do an upper midline incision to free up his stomach before turning him over and reprepping and redraping. It was long an edict on the thoracic service that no patient had a thoracic operation without the x-rays hanging in the operating room. So his barium swallow was up on the screen. And as I was looking at this large hiatus hernia with an esophagogastric junction just a few centimeters below the level of the carina, I freed up the stomach and brought down the esophagus just as you would for a transabdominal hiatal hernia repair. And when we had several centimeters of esophagus below the diaphragm, back into the abdomen, in the process of freeing up the stomach and looking over on the screen, I remember saying that if we have his distal esophagus back in the belly, and on barium swallow, his esophagogastric junction is just about at the level of the carina, we mobilize a substantial portion of his intrathoracic esophagus. And I knew from our experience with median stenoscopy for lung cancer patients being evaluated for nodal disease, that through a neck incision, we could reach down and feel the carina with our finger along the tracheal wall. And that's when I decided that I would try to free up the esophagus from above and below. And I remember these details pretty well because I was operating with my resident, and there weren't any orchestral chords being played. There wasn't a spotlights and all going on. We were just doing an operation, an esophagectomy. But I told the crew that I wanted to fold down the drapes from the patient's head down onto the upper abdomen and lower chest and cover it with a sticky drape. And then we turned the patient's head a little bit and prepped and draped the neck for a neck incision. And we draped again, leaving the abdominal wound sterile and making a new sterile field in the neck with the contaminated drapes covered up by plastic film. And I made the neck incision, got around the esophagus, and completed that dissection, which had been done way up into the chest, as I said, bringing down the esophagus. And it was, I always describe it as as a sphincter tightening experience to be up there in the chest and feeling those the beating aorta going behind the heart and all, but it freed up. We divided it, brought the stomach out of the mediastinum, prepared the stomach, and then put it up through and did the anastomosis. And that's how it happened. The operation, intraoperative blood loss was 1,100 cc's. And when I first wrote about these, I thought that if we weren't ligating those esophageal vessels, we'd have to assume there was going to be blood loss. And so we, in the first several hundred that we did, we asked anesthesia to start a unit of blood as we opened the belly, figuring that we'd lose a couple of units. Subsequently, we learned to control bleeding through the hiatus, and in the last decade or so, they don't set up blood for esophagectomies because we rarely transfuse more than 300. But the operation, we lost 1,100 cc's. The patient required a left chest tube. And my note says the operation was uneventful. The post-operative course was excellent, except that the patient was hoarse. So I bagged his nerve. I must have stretched his nerve in the neck. I also have a note here that on his 8-week post-operative visit, his voice had returned to normal. So I stretched it, but I didn't cut it in two, which was nice. And he turned out to have a T2N0 lesion, a 2A carcinoma. And the last follow-up that I have on this fellow was at 4 years and 10 months when he was doing very well. But I found out that at about 9 years post-op, he died of progressive Alzheimer's disease. So he was a home run. But that patient went up to the intensive care unit, got off the ventilator within 24, 48 hours. We always ventilated those patients for several days. I don't know why, that's what we did. Everybody went to the ICU, everybody got ventilated. And he left the ICU in a week, and we still kept him in the hospital. He went home on day 13, and we don't know why. We just kept everybody in the hospital for that long. And he didn't have an anastomotic leak, and he did fine. So that was the beginning of this transition to transhiatal dissection of the esophagus, and that's how it happened. But I still attribute much of the experience that I had to the I hate to say independence, to the autonomy that we had as Halstead residents at Hopkins, where we could do things that weren't quite orthodox. And I'll tell you that doing an operation that none of us was really had prepared for, had planned. I don't know how that would go over today. In fact, I suspect I do know how it would go over today. It would probably be in the clinical affairs office, and we'd have to be defending what happened, because part of the rigidity that we have nowadays prevents that sort of on-the-spot creativity. But it worked, and it set the stage for what's developed since that time. And so that's the story of my first transhiatal esophagectomy. And I want to make sure, with a disclaimer, I didn't invent this operation. The esophagus was removed bluntly way back in early days of England, where they took out cancer and didn't reconstruct it, just left an esophagostomy and a feeding tube. The Asian surgeons had been resecting doing laryngopharyngectomies, where you really can lay things open and get down to the carina from above, so that there was only the esophagus being resected. The rest of the way was sort of incidental. And they've been doing that for a while. We've learned, incidentally, that the stomach is not of the same length in everybody. The Asian stomach is an average of 2 centimeters longer than the Caucasian stomach, but the Caucasian stomach still reaches to the neck when properly mobilized, and we certainly all know that by now. But when this began and became a movement, that was really contested because some very, very good thoracic surgeons who had just done the esophagectomy the way they had been trained believed honestly that the stomach would reach to the apex of the right chest and no further safely. And that was just shown not to be the case over time. So that's probably more story than anybody wanted to know.
That's great. Did you have like a backup plan? So what if you got there and the stomach didn't reach? Would you just flip them over and do the regular Ivor Lewis?
You know, by then, yeah, by then I had already had 3 years of, at Michigan, we were doing no intrathoracic anastomosis. We're going to put a hole in the neck, and that's what I've been doing. So I had been bringing that stomach up, but I had been opening the chest and taking out the esophagus, and then passing the stomach up through the thoracic inlet and turning the patient and doing anastomosis in the neck. So by then, I had no doubt that the properly mobilized stomach will always reach to the neck if it is properly mobilized. And now when you get a few thousand behind you, you know that's the case. It really is. If it's done right, it works.
So over time, has the sphincter tightening relaxed a bit, or do you still find that
mine has considerably, because I retired from the operating room about 4 years ago, so it's pretty relaxed. But I have my junior faculty are pretty adept at this operation, and everybody has respect for it. I mean, there's no way to make it a small operation, but when you think about how different it is now without a thoracotomy routinely, or without median stenitis to contend with, that was, I remember as a resident with Ronald Belzy in England when I rotated over there as part of the Hopkins rotation, where I spent 6 months in England at that time with a renowned esophageal surgeon. I had 4 patients in the intensive care unit with median stenitis. I was in my 3rd year of residency at Hopkins at that time, and the incentive to do something different, to get that anastomosis out of the chest, was very strong at that point, because there was very little we could do back then. It was a very sobering experience. The trends in the esophagectomy have been interesting as the minimally invasive approaches have come on the scene, and it is it's fascinating to watch some of the experiences of surgeons who are doing the operation minimally invasively. I think there's no question that you can see up into the hiatus more directly and do a better lymphadenectomy. There's also no doubt in my mind that surgeons who do minimally invasive esophagectomies tubularize that stomach far, far more than we advocated. The stomach, as you know, has 4 vascular arcades which keep it alive. And when you divide the left gastric and the left gastric epiploics, that stomach still has 2 hardy vessels, the right gastric and right gastric epiploic, to keep it alive. And the proximal end of the stomach is kept alive by extensive submucosal gastric collateral circulation. And I have said, and will say over and over again, that it is the exceptional surgeon who can kill the stomach. And so when I hear that the stomach, it died, it didn't die. You bumped it off. It wasn't dead when you operated it. The word is that if that stomach is pink and healthy in the belly when you're done mobilizing it, and it's pink and healthy when you get it up to the neck because you haven't traumatized it with clamps and been hard on traction and so forth, if it's pink in the neck and pink in the belly, you'll have a good anastomosis that won't leak on you. And it's the story now that, you know, I'm hearing reports 20–25% leak rates with minimally invasive esophagectomy, or, you know, from a stomach that's been made very narrow, or the run-on tracheoesophageal fistula we're seeing because of the a heat probe going up in the mediastinum to
Yeah.
dissect the esophagus off the trachea, and we're winding up with some ischemic injuries to the airway. But that's neither here nor there. The operation has evolved, I think, in many hands to a minimally invasive video-assisted approach, which is absolutely fine. But it was the contribution was to realize that we could take out the esophagus and effectively restore comfortable swallowing without the need to open the chest and without subjecting the patient to the risk of mediastinitis.
And which resident helped you? Do you know who that person is?
Yes, I know who the resident was. It was Jake. And if I look back on the wall of the hanging pictures, I could tell you who that resident was, but I don't know. It was just one of the residents. It was nothing special planned that day. It was just another day in the thoracic room, but it turned out to be a pretty special day.
Well, I think that's how they usually occurs, to something spare the moment. And, again, thank you for your innovation and, doing it. I think that's the history of it is well known. And so we thank you again for your comments. These were perfect. So thanks so much.
Pleasure. Enjoyed it very much. Good luck, guys and ladies.
Yes.